Hey, it's Dr. Centeno, and this is the COVID Fact Fiction Show, Episode-2. This is a show that really tries to, once a week, dive into what's going on in the news in COVID, but to look beyond the headlines, to dig deeper and try to figure out what's really happening. This is apolitical. I don't care if you're Republican, Democrat, left, right. Doesn't make a difference to me. The focus here is trying to look at what we know from a medical standpoint about COVID and what's real and what's not. So let's dive in for this week. We're experimenting with some different ways to do this, so you can let me know if you like this format or the last format we used for episode 1. So masks, the July 22nd edition. Masks have been super duper controversial, political. I use a mask everywhere I go that I'm supposed to. This is the N95 mask that I wear in clinic every day. So I'm no stranger to masks. Having said that, as I've said in my past blogs, the research isn't that great. We don't really know if masks help. In the meantime, I'm happy to wear one if I'm supposed to. But it's interesting to see, and we're going to dive into it just a little tiny bit here, because the media is really focused on what I call maskageddon. They are just besides themselves trying to prove the point that we're awful Americans who don't wear a mask like we're supposed to. The problem with that narrative, of course, is this little graph. And this little graph was recently published. It's from surveys conducted June 22nd to 28th in lots of different countries. And what's fascinating is that the US is right in the middle of the pack here. What that means is that we're about the same as Germany and Taiwan as mask wearing. And we're beating the snot out of Canada and the UK as far as wearing our masks much, much more often. And we're also beating the snot out of the Netherlands, Denmark, and Finland. So we're doing just fine as far as mask wearing is concerned. And obviously, if masks were really preventing the spread of this thing, we wouldn't have any problems because we're really doing much better than our neighbors to the north in Canada. In fact, if you look at it, 59% of us are wearing our masks here frequently, whereas in Canada, that number was 35%. So we're doing just fine with the masks right now. Here's an interesting one. Scientists, this is a headline I'm reading you here. Scientists report that airborne coronavirus is probably infectious. Now, I went ahead and put like 20 exclamation points at the end of that because that's the job of that headline is to scare you. This stuff is airborne and it's probably infectious. So that sounds really, really scary. So this is about droplets and infections and what we know. Now that particular study was done at the University of Nebraska and it has yet to be published. It was put on a preprint server. But what was the most interesting thing about that to me is that it's not that great. So to review, we're all talking here about the 1 to 3 micron, really, really small droplets that can hang in the air for several hours. And the concept has been, ever since that super spreader event in Seattle, that if we just talk or sing or talk loudly or exercise, these infectious droplets are going to hang in the air and get us all sick. The problem with that is that what the media is not telling you is that the Seattle event was pretty rare. We don't see super spreader events like that being common with people singing or talking. That's not what the data shows. Now here, in order for this study to determine if water droplets that they collected from the air that had coronavirus in them, they obviously got these at a hospital, right on top of someone's hospital bed. In order to determine if these things are going to infect someone else, you'd have to do a study where someone else got infected. There would be an ethical way to do that. You could use 18-year-olds. The likelihood of an 18-year-old dying from coronavirus or COVID-19 is much, much less than that 18-year-old dying in a car crash that year. So it's not a risky study to do, but that's what they would need to have done, is to expose people to these water droplets to see if they got sick. They didn't do that at all. In fact, what they did is they just tried to culture virus out of these water droplets. And even that didn't go so well. They only got 3 of the 18 samples to produce any type of coronavirus in culture, and they never tried to get anyone sick. So they have no idea whether or not these water droplets can actually cause an infection. And if anything, they tended to prove that they probably couldn't, because only 3 of 18 had enough coronavirus in them to actually even culture, meaning to grow in a lab. So now let's talk about the new COVID antibody study out of the CDC. And we're going to talk about 2 of these because these are really interesting studies and incredibly important, but not for the reason the media is talking about for the most part. So the media has been reporting this as, God help us, more COVID cases than we ever realized are out there. Now, obviously, there's another way to look at all this, right? This is the study here, and it was published in the Journal of the American Medical Association. It was 10 sites around the U.S. From March to May, and they looked at the number of people that actually had COVID-19 or SARS-CoV-2 virus antibodies, and their goal was to try to see how many people were actually infected versus how many people were sick. And what they found was 6 to 24 times more patients had COVID antibodies than they originally thought. Now, that is fantastic news for all of us, because it means that this thing is not nearly as lethal as they've been telling us. We have a bunch of people walking around that have this thing, don't even know they had it, and didn't die. So that really improves the odds that you're going to die from this thing. Now, the media, of course, played this as, oh my God, look at all these COVID cases we didn't know about, because that's how you sell eyeballs to advertisers. So what that means to me is if you kind of take the middle number there, 12, 18, let's say, this thing is on average about 18 times less lethal than we thought. So again, think about that. This is incredibly good news for everybody. Now we're going to segue into the Los Angeles antibody data, which is even better than what we just looked at. So this is a study, again, Journal of the American Medical Association, that looked at the number of people who actually had been infected by April 10th and 11 in Los Angeles County versus the number of cases that were reported. And what's interesting here is that they initially had reported that about 8,430 patients had coronavirus during that time. But the new estimate is that around 367,000 adults had already had coronavirus or had it at that time once we start looking at the blood tests. So that's incredible news for all of us, because it means that in this study in Los Angeles County, this thing was 44 times less lethal than previously reported. Again, fantastic news. The jet should be flying over me right now carrying a banner that says this thing is not as deadly as we thought, thank God. But instead, the media took all of this and said, there's many more cases than we realized. Let's all be very, very frightened by that. So now we're going to look at a very important topic, and that is, should kids go back to school? Right? It's back to school time. You'd want to say, hey, should I send kids back to school? Should we not send kids back to school? What's the right answer here? So let's look at Sweden versus Finland. This is a really interesting piece of data. So these are some of the media headlines that we saw this week on this topic of kids going back to school. Healthcare professionals and school board members warn Arizona governor returning to school isn't safe. That's from CNN. New York Times, I won't return to the classroom and you shouldn't ask me to. Education Week, teachers are scared to go back to school. Will they strike? CNN, teachers are so worried about returning to school that they're preparing their wills. So listen, this is a difficult topic. And I want to start this off before we look into the data here by saying that if you're a 60-year-old school teacher with COPD, you probably shouldn't be going back into the classroom because you are at an elevated risk of having severe complications from COVID. But if you're a 30-year-old teacher who is otherwise healthy, you're much more likely to die driving to school during the school year in a car crash than you are dying from COVID. So you being concerned about going back to the classroom is ridiculous. So we have those two boundaries here. We've got the reasonable and the ridiculous, which is one of the problems with COVID. Reasonable and ridiculous are not defined that way. So this is actually a study out of the Swedish government. And what was really fascinating here is we have two countries. One was Sweden, right? Sweden stayed open. They kept their schools open. Everything else was open. Finland did the opposite. They closed it all down, including their schools. And at the end of the day, guess what their infection rate was in school-age children aged 0 through 19? 0.05%, identical in both countries. So both countries had 0.5% infection rate in kids, whether or not they closed society and the schools down or kept society and the schools open. So what does this show? It really means that kids don't really get COVID. They're not even getting infected with it. They're fighting it off well before they actually get an infection and need to generate any type of response. They're literally not real infectable is what this shows. Now, there may be more data that comes out, and I'm certainly open to that data, but this data would argue strongly that there really isn't a reason to close schools at this point. Now let's look at some contrary data, because in this show we look at it all. I don't care what it is, whether it agrees with my personal position or goes the opposite direction. Doesn't make a difference because we let the data talk. So this is from the CDC, and I call this the Korean teen and tween study. What they did here is they looked at contact tracing. So contact tracing is when you actually interview people who have been in contact with infected people. So they looked at about 6,000 COVID cases, and they interviewed about 60,000 people who had come in contact with the original COVID cases. And what they found was the household transmission, meaning getting it in the home, was higher if there was someone who was 10 to 19 years of age in the house. Now, that doesn't mean getting it in the school was any higher for a teacher. That doesn't mean that this teen or tween giving it to the local shopkeeper was any higher. These are close contacts, and this has been a trend throughout COVID-19. We have seen many times and time again that this is mostly infectious amongst close contacts, meaning people in the same household, and there are super spreader events. But this is not, the data does not support that anyone is catching this or that many people are catching this by walking by someone without a mask. It's critical to understand that we have the super spreader events, which is where someone is, for whatever reason, a super spreader and gives it to lots of people. That was the Seattle choir event. Or on the other end of that spectrum, we have where it's really transmitted, which is in the home. So again, Korean teens and tweens infected more people at home than younger kids or adults. So what does this study say? It doesn't really tell us too much about school, but it does seem to suggest that maybe they can bring it home and give it to their elders. The good news is most elders of teens and tweens are going to be in their 30s and 40s. So they're going to be, again, very unlikely to die from COVID. But certainly if there's an older person in the house who's 70 or 80, that could be a real concern. So how do we compare the quality of these two conflicting studies? We've got an observational study with millions of school kids in two similar countries. One stayed open, the other shut down. And we've got a contact tracing study. So contact tracing is really tough. And let's demonstrate how tough this is. Tell me right now, every person you came in contact with over the past 2 weeks. Even tell me every person you came in contact with today and yesterday and the day before. And oh, by the way, I need their names and their phone numbers. Which ones did you hug or touch? Which ones were you less than 6 feet apart or more than 6 feet apart? Which ones had masks on when and which ones didn't? As you might imagine, just doing this for yourself right now, you're going to really struggle to come up with many names and to come up with everyone you came in contact with. So contact tracing by its very nature is extremely flawed. It may be very helpful in determining an outbreak, but in a pandemic, in order to drive public health decisions, which is what we're talking about here, contact tracing is kind of a nightmare. So hence the edge here goes to the Sweden-Finland study, not the contact tracing study. Now again, that doesn't mean that I'm saying that we should send kids back to school. But what I am saying is the medical research right now would tend to favor sending kids back to school and keeping teachers out who are at high risk, but letting the rest of the teachers go back and teach. So the good news, this has been bad news after bad news after bad news, or some good news that was portrayed by the press as bad news. So let's actually talk about some good news. Pre-existing COVID immunity is really, really interesting. And what I mean by that is it possible that there's some cross-reactivity or cross-immunity with other coronaviruses that cause the common cold? Is it possible that some people who have robust immune responses to common cold coronaviruses don't get COVID? So this is super duper interesting. This is a Mayo Clinic expert in antibody production by plasma or by cells, and who's a cancer researcher into the immune response and how to treat cancer, who was on Meet the Press, and he brought this up, and I thought it just was really fascinating, good news maybe for all of us. So what's super fascinating about this Mayo Clinic doctor is he talks about how these hotspots get to about 15 to 20 to 25% positivity rate for COVID, and then they really don't go much higher. That includes New York City, Italy, etc. He also talked about how there's cruise ship examples where people have spent 20 days in the same cabin, and a man, a woman locked in the same cabin, let's say the man's positive, the woman never catches COVID. And his thought that this could be explained by existing immunity to other common cold coronaviruses, and that we should start looking in this direction. So this is just the musings of a very educated guy on this topic, but I thought it was pretty interesting nonetheless. So heparin and the spike protein. This is really cool because this came out this week, and the concept basically is that we have the spike protein on the outside of the SARS-CoV-2 virus, and it's what it uses to gain access to the cell. So almost like a lock and key, it goes through this ACE2 receptor on the surface of cells, but basically it's how the virus gets into the cell. So why this is super interesting is that heparin is a cheap blood thinner drug, and it's widely available, and we know that COVID-19 patients have problems with clotting, meaning they're clotting too much. So they're really talking about, and I'm sure there are some physicians doing this, anticoagulating these patients, giving them things like heparin to make sure their blood doesn't clot very much. So if heparin can bind to that spike protein and block its ability to get into cells, it's kind of a 2-for treatment. On the one hand, you're blocking, obviously, the virus from getting into the cells. On the other hand, you're helping the blood clots. So this is pretty exciting stuff. Now, this is through Rensselaer Polytechnic Institute. They did some experiments with the SARS-CoV-2 virus and heparin, but super exciting to hear that super simple concepts like this that are cheap and widely available may be able to help patients. So that's it. Thanks for watching COVID Fact Fiction. This is episode 2. We're trying different formats. Let me know if you like this format. Make sure you like the video or the podcast. And again, our job is an apolitical medical science look at what's really going on. So thanks so much for watching or listening, and have a great day.